Welcome to This Week in Health IT, where we amplify great thinking to propel healthcare forward. My name is Bill Russell, healthcare CIO coach and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. If you missed our live show, it is only available on our YouTube channel. What a fantastic conversation we had with Director 4 David Muntz, Sue Shade, around what's next in health IT. You can view it on our website with our new menu item, appropriately named Live, or just jump over to the YouTube channel. And while you're at it, you might as well subscribe to our YouTube channel and click on Get Notifications to get access to a bunch of content only available on our YouTube channel. Live will be a new monthly feature only available on YouTube. How many times did I say YouTube in that paragraph? Subscribe to YouTube. We're going to have some great stuff over there. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. They reached out to me to see how we might partner during this time, and that is how we've been able to support producing daily shows. Special thanks to Sirius for supporting the show's efforts during the crisis. Now, on to today's show. Today's conversation is with Dr. Jake Lancaster, CMIO for Baptist Memorial Healthcare out of Tennessee. Good afternoon, Jake, and welcome to the show.
Glad to be here, Bill.
Well, I'm looking forward to this conversation. Thanks for taking a few minutes. I know you guys are busy. You've been in this role for all of 9 months, and so I guess you sort of got the welcome to Baptist Memorial. Are you ready for a pandemic kind of intro to the job?
Yeah. Been here 9 months, but it feels like about 2 years for sure.
Well, yeah, I would imagine. So, I mean, what was that like? I mean, you were in the role probably for about, before we started hearing about it into China, you were probably in the role for maybe 3 or 4 months, and then it really ramped up.
Yes, definitely doing a lot of different things now than what I was doing the first few months. I was really focused in those first few months on quality and safety initiatives and really improving the experience of the EMR with physicians. But yes, over the last 2 or 3 months, or 2 or 3 years, depending on how you're looking at it, it's been all COVID and trying to plan and prepare for the pandemic and do all we can to make sure that we're treating patients and taking care of our staff as safely as possible.
Yeah, and we're going to get into some of that. But before we do, tell us a little bit about Baptist Memorial, because you're the third Baptist we've had on the show. So I want to make a distinction for people.
Yes, we are the Baptist Memorial Healthcare Corporation that is based, our corporate office is based out of Memphis, but we have 22 hospitals as well as many clinics across 3 states, so Tennessee, Arkansas, and Mississippi. Our 2 largest facilities are in Memphis and then Jackson, Mississippi. Okay. But we have, several thousand employees, close to 4,000 providers that touch our healthcare system.
Fantastic. All right, so we're gonna touch on the work leading up to the really a pre-COVID era. Some of the things that may be going on today, and then I'd like to, if you'll allow me, start talking about coming out, because we saw some numbers this week that show a little bit of an uptick in terms of claims data, which would say that some of the OR capacity is starting to rise and those kind of things. So I'd like to sort of finish there. But let's start with, how did you ramp up to handle the pandemic, and what did you learn in the process?
Yeah, so in the very beginning, the executive team, we were meeting about 7 days a week, oftentimes 2 or 3 times a day, in order to prepare for the pandemic. Initial phase, just like everybody else, we were focusing on screening, which just that seems so far from now. Just the travel history, making sure all that was built out in our EMR, making sure that came across well. I mean, which is not as relevant now, but that was a big deal those first couple of weeks, as well as standing up our reporting, standing up and making sure we had adequate PPE. At that time, we didn't have any idea of what the case volume was going to be like. So we were relying on a lot of the models that were out there, like Chime and some of the others, to try to predict what it was going to be like in our area. And really during that time, that was the first couple of weeks when everybody's hair was on fire. We started to show what the projection was and when it was supposed to hit in our area. That got people to step back a little bit and realize that this was going to be a marathon and not a sprint, which I think helped a lot. It helped and it hurt somewhat. When we started talking about this going on for several months as opposed to 2 weeks to a month that some had initially predicted the worst was going to be. It freaked some people out for sure.
Yeah, it's the marathon aspect of this. We were talking earlier how, people are just getting a little stir crazy and, things are happening. I was talking about what was going on in my area. You were talking about what's going on in your area. But that's what I would really want to focus in on. What is going on in your area? Like, number of COVID patients maybe that you're treating, and are you starting to open back up? What's going on in the markets that you serve?
Yeah, so Tennessee, Arkansas, Mississippi are all slightly different in how they have been impacted by COVID. Tennessee and Mississippi have been hit slightly harder than Arkansas, and Memphis and Jackson, the bigger cities, more so than the others. But Jackson having slightly more than Memphis, we think because of the proximity to New Orleans and Louisiana. So over the past couple of weeks, you've probably seen on the news where all three of the states really have had these reopening plans, and so we've been able to take our states open over the last 1 to 2 weeks, with different states having different timelines and different criteria for what's allowed. And so even before the reopening plans, things were fairly stable. We didn't have a huge number of cases. System-wide, our total number of admitted patients has been 100 across 22 hospitals, with probably 30 max admitted at any one hospital, with maybe about 20 med surg and 10 ICU. So, during our surge planning, we had prepared for probably 10 times that, close to 10 times that. So, pretty far from what we thought our ultimate capacity was for COVID-19. But even before the state started reopening, like I said, it was leveling off, but actually our case counts had started to tick up, largely because we think we were testing more. So around that time, we started testing every patient that was admitted to the hospital. And not false positive, but our asymptomatic positive rate has been around 2 to 3%. Which is, it's low, but when you're testing hundreds and potentially 1,000 patients, that's going to be a significant number. And so we do have about 10 to 15 patients admitted across our system that are asymptomatic positive. So that looks like our numbers are going up, and they are technically, but that it may also be that we're just doing a lot more testing. So, the states reopened a couple of weeks ago or a week and a half ago. We started testing everybody that was coming through the system. And so now we have this scenario where our cases are slowly picking up. And so we don't know if that's due to the state's reopening or if that's due to more testing. And so it's a little bit hard to understand where you are in the process. But to me, the good news is our ICU patients with COVID has been relatively stable over the past several weeks. So those numbers aren't really going up as in that same fashion as the rest of them. So to me, it looks like it may be more due to asymptomatic positives, but certainly going to be interesting to watch over the next couple of weeks as we get more data.
So your hospitals are opening up. What kind of things are you putting in place? I mean, this is the thing that every health system across the country is dealing with right now. It's like, how do you create that safe environment? You don't want people coming in and getting COVID at the hospital. So
right.
What's the new norm going to be like for me when I go to the hospital?
And everybody seems to have a different take on how to do this. What we have in place is called the COVID care system, is what we're calling it. So like I mentioned before, everybody that's coming to the hospital, everybody that's getting a surgery is getting tested for COVID. And you're going to be put in 2 buckets. You're either COVID positive or COVID negative. And then based on that diagnosis, we're going to put you in either a COVID care zone in the hospital or the COVID free zone. And so that's kind of how we're laying it out. We obviously have full PPE for everybody that has been revised based on CDC's guidelines as they keep coming out. And then at the same time, we've been toying with the idea of testing antibodies on all these patients as well. And that was initially part of the COVID care system and still is technically. but we're really waiting on the final guidelines or final decision coming out of what those antibodies actually do for you. So the thought was we would have so-called COVID competent patients and physicians or care providers that had COVID antibodies that could potentially be safer when treating these patients, or put in different zones of the hospital depending on their risk level. And then the COVID naive patients and COVID naive providers that did not have antibodies at all. So really that is kind of where we're steering. We have this, these long Visio diagrams of 30 slides about what to do in what situation as the patient enters this particular area, whether it's an outpatient clinic or surgery or, going for cardiac rehab or something like that. And so depending on their testing status, depending on what the procedure is, kind of dictates where and when, that patient should go. At the same time, we need to test the workforce, which has gotten a little complicated. So our employed physicians, our employed staff are easier. We can test all of them, require testing. We're starting to do that. That has been kind of our second process after testing all patients. We've started testing all really the frontline providers. Started with our 2 largest hospitals and expanding to the rest earlier this week. And so we're testing all of them for the disease. And luckily, our rates for those have been really low. So after testing about 2,000 clinicians, only 1 or 2, I think, tested positive, which was much lower than we had expected given our asymptomatic positive rate for patients. But now we're starting to look into how do we test our contracted employees? How do we test the independent physicians and our contracted staff? And so those questions are a little bit trickier because we really do have to get legal involved and wade through the contracts about what we can and cannot do and what can we require and what can't we require. And so that part is a little bit trickier than the employed staff, the employed staff is going well.
Well, how often are you going to do testing? So, that becomes the $1 million question, doesn't it?
Right. And everybody you ask has a different answer. We don't have a set answer yet. We are going to get a baseline, just test everybody and see what our raw numbers are, and then make a decision based on that. Because, theoretically, you could retest every 3 days, every 5 days, every week. Some are saying every 2 weeks. There's not a ton of science behind any of this right now. Luckily, with the new guidelines released by the CDC, you no longer have to do the straight nasopharyngeal test, that really long one that goes all the way to your skull. Now you can test, nares and something a little shorter. So that staff have really appreciated that for sure, and makes it a little bit easier for complying with testing. But once we get an idea of how many of our staff are actually positive, we will come up with a retesting plan. We have it tied to their employee record, so much like when your license is going to expire, we know when your test could potentially expire, and we could call you back in for retesting.
Yeah, I talked to somebody who had the nasal swab done, and they said it felt like they were touching my brain, and actually, it's not comfortable.
Oh no,
to say the least. All right, so let's talk about let's talk a little bit about the business, if you're okay, talking about the business of healthcare a little bit here. So we did away with elective procedures and whatnot. It created a financial strain on the health system. About 250 health systems across the country have done furloughs and those kinds of things. So there's something about getting this engine going again. And there's an awful lot of people who are sitting at home waiting for, we call them elective procedures. So people think, well, elective meaning they're choosing to get them because they want to. But in reality, these are serious procedures for very uncomfortable situations. How quickly are we going to be able to ramp some of that stuff back up and get those ORs really functioning at capacity in those clinics and other places?
Yeah, so we have a little experience with this since we started resuming some elective procedures about a week and a half ago at all of our facilities, 2 weeks at some of our others. It depends on the state, what you can do. some states require that you can only do certain procedures, and they lay that out. But the ones that we've resumed, elective procedures, it's certainly not back up to our pre-COVID levels, but in some cases it's 60 to 80% of our volumes from prior, which is encouraging. We're keeping a daily running dashboard of kind of where we were last year at this time with each surgery and each procedure, all the way down to each physician. And we can kind of see what level they are versus the prior year. So it's interesting to see. We get some feedback from patients about, why they didn't want to resume or reschedule this procedure, and some are frankly scared, have come to the hospital and they're fine with putting it off a little bit more. We have our physicians and others calling the patient saying it's okay, it's safe to resume this. We have this COVID care system in place. Here's our plan to make sure you're safe, X, Y, and Z. And then in a lot of cases, these patients have been waiting a long time. A lot of cases they were waiting a long time even before they were scheduled to begin with. So we've had a lot come through, but then there's a few, maybe some that have comorbidities and are sicker than others that are looking to keep putting it off.
Yeah. Do you think, do you think there was some demand destruction? Do you think there's sort of this group that is just not going to come in those couple of months? Like, are we going to be able to recapture that revenue, or are we just going to draw a line in the sand and say, okay, starting from here, we're going to try to get back to 100%?
Yeah, I don't know. So the groups that I don't know we're going to recapture, and I'm not just talking about surgeries, I feel like the ones that actually needed procedure will come back at some point in the future. Now, the outpatient primary care visits, the ED visits that were always kind of on the bubble of, did this person really need to come in for this? Some of that's going to be captured via telemedicine. I think, some of the worried well that wanted to just see a doctor about something, they're going to go through telemedicine. But I have a feeling that some will probably just not be recaptured. And then telemedicine visits probably aren't going to end up in the end paying as much as an inpatient visit will.
So let me ask you this: do you think this will fundamentally change how the emergency department operates? Do you think we will see a lot of diversion over to telemedicine, and just people think about the emergency department different moving forward?
To me, yes. I think the acuity in the ER is going to go up because people are going to wait and put off coming for as long as possible. The patients that I used to see coming in at 2 a.m. with back pain they've had for 3 years, that's not going to be there for a while, I wouldn't think. I think that patient is going to be seen via telemedicine. There's all sorts of that chest pain that, maybe it's real, maybe it's cardiac, or maybe it's anxiety that maybe people are going to wait a little while longer just to see if it goes away. And in some cases that we've seen across the country where that's led to heart attacks that have been missed and people dying at home. And so there's real worry about that. But in the short term, I think that ER volumes, which are down at our facilities, 30% or something along those lines, aren't going to return to their prior COVID baselines, in my opinion.
How has this juggled your projects and your priority for projects coming out of this?
What projects? Over the last 2 or 3 weeks, we've started picking back up on some longstanding projects. So we went through with our upgrade. We were the only system that actually did that. We were initially going to be like 7th in line for this Epic upgrade, and we were the first system to take it live for the new version. But and then we're starting to pick back up on the rest of our projects. That was kind of the first major thing, and then we're doing all these AI sepsis implementations, things of that nature that have recently started back up. It's slow, but at the same time, our daily, I was meeting 3 times a day to talk about COVID-19 with 4 or 5 other meetings in between. Since we've gotten most of those processes kind of ironed out and in place, I have a lot more free time during the day. And so we need to find other things to do and go back to the other things that were mission critical. So it's definitely gotten to a point where we can resume some of the other projects, some of the trickier things like needing on-site support for certain things. have maybe delayed it a little bit more.
And last question, and again, I really appreciate your time. Everyone's talking about a fall resurge of COVID patients. How are you planning for that? I mean, if you ramp up your hospitals, do you have a way to sort of fall back into increased capacity?
Yeah, so I mean, we have our surge capacity plans that are in place, and like I said before, we had planned for close to 9 to 10 times the numbers we're seeing now. We're going to keep watching this. We trend the data daily and keep watching to see what is happening in our state and local levels, and we can go back to that contingency planning and that staffing plan if we need to. I don't think we're going to stop tracking that anytime soon. And what we have in place for our ventilators, our extra staff, our extra capacity is not going away. It'll still be there. The thing we'll have though is we have all these processes in place already. We have our PPE supply chain in place. We have our telemedicine solutions in place. We don't have to reinvent that. It's just going to be turning back on.
Fantastic. Jake, I appreciate you taking these questions. Next time I have you on, we're going to talk analytics. We're going to go into, we'll go into informatics. We'll go into all the fun HIT things that I love to talk about. But I appreciate you just as a system that's starting to step out of this, giving us a little precursor to what's going to go on across the country.
No, thank you. And thank you for doing these shows. It's been really helpful.
I appreciate it. Thanks again. That's all for this week. Special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, Health Lyrics, Sirius Healthcare, and ProTalent Advisors for choosing to invest in developing the next generation of health leaders. If you want to support the fastest growing podcast in the health IT space, the best way to do that is to share it with a peer. Send an email and let them know that you value and you are getting value out of the show. And also, don't forget to subscribe to our YouTube channel while you're at it. Please check back often as we will continue to drop shows until we get through this pandemic together. Thanks for listening. That's all for now.